Thank you very much. Good morning, everybody. Important topic, and I'd like to use the next 10 minutes in order to get you some ideas and plans and hints how to cover these sorts of injuries and try to avoid what we see on the right side of the picture. Preparation, like in all fractures, is everything. We use a supine position, radiolucent table, knee in flexion or enable flexion, either by a bolster or letting the leg hanging a little bit supported by your knee from the table. Good C-arm is absolutely crucial. The larger the field, the better. Two monitors gets the contralateral leg out of the C-arm, and we use this obstetric leg holder, elevates the ipsilateral leg and lowers the contralateral leg are the alternatives, but we prefer the obstetric leg holder. The entire leg should be draped, no tourniquet at all, and a very important, even before you start operating, you should check clinically your contralateral side in terms of length, hip range of motion, do the hyperextension test, and radiographically make a shot of the lesser troch of the contralateral side and store it in the image intensifier's memory. Quick brief review of the AO classifications. AO classification, this is one of the very few locations where the classification is helpful. And the plan is very easy. There are these simple fractures, extra-articular, complex, intra-articular. And when you have complex intra-articular, you make them, you stabilize them, you build a block, an articular block, and by this you make an extra-articular fracture and just continue as you would do with an A-type of fractures. The approach concept has changed in the last 2 decades, and very helpful is the lateral parapatellar approach, which addresses all C1 to 3 type of fractures. And if you have Hoffa type of fracture, you can use this for the lateral B2 type. And if it's on the medial side, you just do the reverse on the medial side with the medial parapatellar approach. This gives you the opportunity to really display your articular surface, also the posterolateral part of the medial the posteromedial part of the medial condyle, which is usually very difficult to approach. But with the patella reflected to the medial side, you can really do even very complex destroyed joints, but just make sure you go high enough with your incision in the tendinous part of your quadriceps tendon. If it's an extra-articular situation, a direct lateral approach is most useful. Don't make a mix of anterolateral and a little bit more medial. Just stay straight, purely lateral to the bone, and avoid difficulties in placing your implant. If you have B-type fractures and it's difficult for you to access the posterior part of the condylar fragment, an osteotomy of the ligament is not a difficult thing to do. Makes a bone block big enough in order to have enough purchase to refix it after you have achieved your reduction goal. Very important, the tools, the reduction tools, bone hook, laminar spreader, very important to open up the fracture and brush it out with either the brush or the pulsatile lavage, king tong clamps, all sorts of other clamps, very helpful. These collinear clamps, we come later to it, and also this 2-part wire parser. External fixator is helpful for temporary achieving reduction. Joysticks are also very helpful, but keep in mind having a joystick only in a single way gives you good, for example, like here, flexion extension. But if you need to do small rotation, you end up in problems because you just screw in your shunt screw into the bone. So it's much better to use 2 shunt screws, and then you have something like a bicycle handle, and in any direction you can direct your fragment, and you have much better control over your fragment. Problems are the horizontal fracture lines, and when you have bulky screw heads, they do interfere with the joint. So make sure you deeply insert them into the hard bone where they still have enough apertures. Very, very helpful provisional fixation of the articular block to the shaft is with small mini plates. If you do it with K-bars, you frequently slip off. So small placed 1/3 tubular 2-hole mini plates are very good in terms of achieving anti-glide function, good temporary stability, but it still gives you some flexibility to do the fine-tuning for example, rotation or varus valgus mal alignment. Provisional fixation to the articular blocks. This works even in extreme situations where you have still only 15 millimeter left to the articular surface. Be not shy in shortening your dirty, mud-impacted shaft fragment. Do not try to keep lengths for any price for the risk of contamination and infection, because lengths nowadays can be achieved with lengthening devices without big efforts. So make sure you get a clean construct and a stable fixation to your distal main fragment. The problem in this floating knee situation is once you have built, let's say, the distal tibia to the shaft, and then you start building the proximal tibia, and you might end up with a deformity and an obliquity of your knee joint line. And a very good tool to avoid this is this alignment rod, which has an add-on 90-degree sort of transverse tool, and you can put it onto your leg or leg and center it to the hip joint and center it to the talus, and then you have a defined 90-degree rectangle, and this is helping you in this complex floating knee situation. Here the patients after secondary lengthening with an motorized nail and achieving a reasonably good result in his 4-year follow-up. Plate placement can be a little bit tricky because the plate, before it is fixed, it always tries to float around in 6 degrees of freedom. So you can help yourself a little bit by fencing the plate. You can do proximal plate fencing above and below the plate, and you can do it distally so that you have some sort of a defined maximum distal implant position, but you still have the freedom and still have the ability to do the rotational fine-tuning in order to achieve a good alignment. Temporary fixation of the implant to the plate is very important. In the old days, we had this conventional clamps, which required a large soft tissue dissection. With the 2-part properties of these collinear clamps, you only need a small incision, minimal soft tissue dissection in order to achieve your task. Also, a very nice thing is that this thing is a hollow device, so you can avoid slipping off round surfaces and oblique surfaces by inserting a K-bar before, and then you slip over the collinear clamp, and you are very sure that your construct does not slip off the bone and off the implant anymore. Also very helpful, large distractors. The concept is that you put in your shine screws through the A-hole of your locking plate, but still are able to control rotation, length, and sagittal alignment. So this gives good provisional stability for your construct. Don't get fooled by your image intensifier. Question here is this plate centered properly? On the first view, it seems yes, it is, but when you analyze your projection of your X-ray beam and your position and of your plate construct in space, you realize that you're very close to the posterior posterolateral cortex, and if you only a little bit slip off, which still looks good on a true lateral X-ray, you are already off the bone with your locking screw. Here, such a patient, elderly patient, 88-year-old Ruth, with this periprosthetic distal femur fracture, got a locking plate. Screw position in the proximal end, also a little bit questionable during the course of treatment. There is a pull-out of the proximal plate end, and well, how can we solve this? Okay, one step would be longer plate, but the other smart thing to do is combine the best properties of your implants in order to a good total property. So circlage wires are good for against pull out and pull off the plate from the bone, but very weak in terms of shear. But the screws are very good in shear, but they are very weak in terms of pull-out. So combining these two things is a smart thing to do, as we see here in this clinical case. And the two components, circular wire passer, also very helpful. You avoid dissection, but you can control your plate temporarily. You can use a circlage, and you can tighten, you can loosen your circlage. This gives you a very good good control of your implant position to the shaft, while still able to, you are able to control the patient's rotation. So there are a lot of things to consider in the treatment of distal femur fracture. Let me summarize it. Pre-op alignment analysis of the contralateral side is a very important first step. Different approaches for extra and intra-articular fractures. Have a look closer on these things. Reduction tools, there are many, and they all have their specific role. And fixation concept, make a A-type from a C-type, use mini plates, fencing K-wire cages, and circlage, temporary locking. Screw combination is helpful in order to address even complex fracture situations. Thank you very much for your attention.